Okay, greetings everyone. My name is Dimitri Prybylski. I'm an epidemiologist with the U.S. Centers for Disease Control and Prevention, or the U.S. CDC. And it is my distinct pleasure and honor to be presenting to you on an overview of public health and epidemiology and some concepts and principles and then some applications to infodemic response. I have three learning objectives. One is for you to learn how infodemics cause public health problems. Two is to gain familiarity with key epidemiological concepts and principles. And then also to understand how these principles and methods may be applied to infodemiology and infodemic management as well. So, number one, I'll apologize. I have a bit of a sinus infection and a little bit of a cough, so I apologize for that. Two, I only have 30 minutes, so I'm going to be going pretty rapidly through this material. I have links and footnotes at the bottom of slides, and also I'll be giving you a whole bunch of resource documents, materials to have to read through at your leisure as well. So let's start with the first objective, which is learning about how infodemics cause public health problems. So misinformation has been around a long time in public health and outbreaks. The first panel over here is actually an illustration from 1802, and it shows a cartoon of cowpox inoculation and how getting that inoculation is actually causing people to turn into cows. It's a pretty morbid diagram and quite visually effective. I certainly would be frightened if I saw that. And then there's another on the other side of the panel is an older one, even from 1656. And you'll see this is a doctor who's dressed wearing this looking like a bird, actually. And it was really a physician who was treating the plague, and that the belief at the time was that you wouldn't be harmed by the plague, which was associated if you wore this particular outfit with the because it was believed that plague was associated with miasma and birds, and so this would be somehow protective, and this was a source of obvious misinformation. And then a more contemporary example is related to the HIV response and how, or the HIV pandemic, and how there was a widespread belief that the HIV virus was a secret weapon to wipe out the African race, and another source of misinformation that got a lot of traction as well. So just want to run some numbers by you in terms of the COVID-19 infodemic. Number one, showing, this is looking at February and March, just the volume of unreliable information and reliable information. And so just the sheer volume alone can create infodemics. It's this overabundance of information or misinformation. And then trying to, as you're being bombarded by this, to differentiate what's reliable and unreliable. And indeed, when American adults were interviewed, they clearly were reported being overwhelmed by the amount of information on coronavirus coverage across age groups. And additionally, 8 out of 10 Americans say that misinformation is a major problem in the time of COVID-19. In April, health misinformation pages were viewed 500 million times on Facebook alone. 82% of online content posted the first few months of the pandemic online were false too. So highly problematic that this was happening. And unfortunately, this had dire consequences. When people are exposed to misinformation, we have direct examples of how across the globe, how in this case, how the misinformation that methanol was a cure for coronavirus led to mass poisoning in Iran, where approximately 800 people have died and close to 6,000 have been hospitalized, and 60 developed complete blindness as a result of drinking methanol. And then also unproven herbal remedies in Madagascar had negative public health consequences. People got sick. And in the US, we had a lot of, I think we had some morbidity, serious morbidity and mortality associated with the unsafe use of cleaning products as well. So these are direct examples of that. But it may turn out that the true impact of misinformation is underestimated. And these are just some a summary slide from the publication by Swar Thompson and colleagues that came out recently. And they report that, while surveys have been done showing that only 3% of people in the U.S. Say they feel that they've been harmed or reported knowing someone else has been harmed by information found online, that actually may be more a fact of the fact that more of the reality that they just aren't aware about what's really happening. And they give the example of alternative medicines alone curing cancer as a source of major misinformation that's been circulating for quite some time now, and that 39% of Americans believe that alternative treatment alone can cure cancer. And when you combine that with the lifetime risk of being diagnosed with cancer, and then additionally that the 5-year risk of death from, for example, colorectal cancer is over almost six times higher among those receiving alternative medicine versus conventional medicine. This is a Kaplan-Meier curve showing that the survival fraction, how much lower it is for alternative medicine. If you look at those different statistics together, you can realize that there may be a much more widespread problem, and that it can be that individuals are not being noticeably harmed by information that they find online, so they just are unaware. So now we'll turn to reviewing some key epidemiological concepts and principles. So epidemiology has been around for a long time too, and it has a pretty solid track record. Some of the pioneering work was done by John Snow, who's considered one of the founders of epidemiology, and not the same guy who stars in Game of Thrones, but nevertheless, quite a figure. And one of the things that he really brought to the table in terms of investigative technique or field epidemiology was he was mapping where cholera cases were in central London. And he noticed that they were distributed in around an area where there was a pump, a water pump, and this led to the intervention of removing the handle of that pump and making it no longer useful or usable, and that actually ended up ending the epidemic or the outbreak. And so, I think that was that's an example you'll see in every Epi 101 textbook. Here's just a really interesting, I thought, Epi curve looking at the percent of the population who are dying in different U.S. cities from 1918 to 1919. Now, clearly, this was pre-PowerPoint, but you are a lot of the same concepts of looking at the proportion of a population who was dying as opposed just to the raw numbers, fairly advanced concept. And then this is a publication that came out recently in 2007 in the Journal of the American Medical Association, which basically looked at the historical archival research and data that was available during that time and reanalyzed it. And their findings demonstrated a strong association between early, sustained, and layered application of non-pharmaceutical interventions on mitigating the consequences of the pandemic. And this is all based on the historical data with some additional modeling that was done. But, it just goes to show that sometimes just having data alone isn't enough. It has to be translated into public health action. And I think you'll be hearing more about that in a great interview that's going to be coming up later on. I don't want to ruin the surprise. And then also just to indicate that there have been advances in epidemiology, in this case, in this example, in molecular epidemiology more recently, where molecular microbiology tools have been used to study the distribution, the determinants of disease in human populations as an additional tool in the arsenal of methods that are available now in EPI, and bringing in the whole lab component in a very rigorous and sophisticated way, doing phylogenetic analyses, etc. So for tracking outbreaks or epidemics. So speaking of those terms, it's a good thing to differentiate them, what they mean as well. So let's just go through some of those key terms. So epidemiology is really the study of diseases and other health outcomes, their causes in a population, and how they can be controlled. And a way to think about this is that, you know, doctors are really look at patients, and that's their who they're interested in. Epidemiologists look at communities or populations as their target population, as who they're interested in. And that's how we kind of conceptualize a lot of what we do. Outbreaks are a higher than expected number of occurrences of disease in a specific location and time. For example, there may be an outbreak, a foodborne outbreak in a restaurant that requires field investigation and workup, but it tends to be in a more specific venue or area or place, you know, either caused by infectious or non-infectious causes. Environmental causes are often caused as well. And then you have epidemics, which are more a sudden increase in cases of a disease, but generally over a larger geographical area. And these are often picked up using surveillance systems, which we'll be talking about more as well. Pandemics are epidemics which are distributed more across several countries, or in the case of COVID-19 or HIV, you know, globally, and that obviously has huge global consequences affecting a much larger number of people. So epi curves, I showed you the example from the handwritten example from 1918, 1919, but that's an epi curve. And it shows what has happened, including the number of cases, or the number of cases dying per population, hospitalizations or deaths, or some other indicator as a function of time. And we're going to talk more about public health surveillance, which is the systematic collection, analysis, and interpretation of health data. And public health surveillance has certain key attributes. One is that it's ongoing and systematic. So unlike a lot of field epidemiology, which is where you do an investigation in response to a particular event, public health surveillance is based on routine information systems that are tracking behaviors, disease, other things as well in pretty sophisticated ways, and they're looking to see if they can detect something that's gone wrong in terms of an increase in cases, and if there is an increase, where is it happening, when is it happening, what subpopulations are being affected. And so it involves a collection, analysis, interpretation, and timely dissemination of health-related data. Again, if you do all this hard work, but you don't disseminate it for public health action, it's not going to have a lot of great consequence. It's a really important lesson. And then really reducing morbidity and mortality and improving health are the ultimate objectives of public health surveillance. So public health surveillance can be seen as a cycle where you're detecting it, you're collecting information, compiling, analyzing data, interpreting it, communicating it to key stakeholders as well, and then taking action. And this is something that happens as the surveillance system is routinely collecting data in terms of how you respond to different types of events. And its real function is to monitor trends over time in a population, and then patterns geographically as well among different populations and subpopulations. This slide, I think, is really a very crucial slide. because it shows how information and surveillance data and study data, gets collected at, local district level for in a particular country, but then that gets reported up to the intermediate level. It goes up to the ministry level, Ministry of Health level, where the data will be disseminated in a national epidemiologic bulletin, which may come out every week, for example. And then across countries, that data goes and gets consolidated and aggregated and gets reported out, like in the weekly epidemiological record or regional bulletins as well. And then information is then fed back to countries, this information back to countries in terms of feedback for improving surveillance or in giving expert advice and guidance in terms of how to respond to public health things that may have been detected as well. And there's a really complex array of information systems, of reporting structures and systems that have very detailed standard operating procedures associated with this. So when you see the cover of the WHO COVID-19 weekly epidemiological update, which has an interactive dashboard as well, with some really interesting and beautiful data that's being reported out here based on the number of cases reported by week, by geographical, by different region of the world, including deaths. And then over here, looking at sort of global distribution of cases per population, cases reported in the last seven days, so more recent or infections. And all of this is based on the backbone of this kind of reporting structure. It's really hard. Sometimes it's easy to underestimate how much work it goes into generating this kind of information, and how many offices, staff, communication going different directions are required for that. It's something for us to think about as we think about infodemiology. So I'm now just going to try to briefly go through some of the epidemiologic methods we use here at CDC for COVID-19, but this can apply to really any epidemic or pandemic for that matter. The first is identifying the source of the outbreak, and I'll start there. And so this is this is something that's based a lot on field investigation, and I don't have time to go through it, but there are 10 steps in field investigation. Can provide you more information about that, but how you conduct it requires some real thought about in terms of preparation, in terms of collecting data, analyzing it, and then using it for public health action. It's often involves conducting surveys in the community or at health facilities. It sometimes involves collecting, quite often, biological samples from the nose or throat or from your blood, and then conducting sophisticated lab analyses on that as well. And then you use that sort of lab data in coordination with additional information to help inform who was infected, when they became sick, and where they had been just before they got sick as well. And this is all to figure out what the epidemic source is. And then there's really this monitoring and tracking of the disease, which is more this sort of surveillance function I had mentioned earlier, where in this situation, you're really using case reports. And the case reports include data on these various factors, which I don't really have time to go through step by step or item by item. But that ends up being, you collect this data, you aggregate it, and you can look at how these different indicators relate to each other to answer some really important questions too. And then the third step was really studying the disease so that CDC and other agencies and institutions around the world, they're conducting thousands of epidemiologic studies to understand the time between when someone is exposed to the virus and when they have symptoms, which is the incubation period, how long a person who's infected can shed the virus, and the range of signs and symptoms and severity of disease, the risk factors associated with severe disease, and also how often the disease causes illness and death as well, and how often the disease causes illness and death in a population. So you're looking at then rates of death and illness in a population as a function of the denominator is the population. And then you also study the disease, and there are different types of study designs that can be used as well. One of them is the cohort design, and that's where you track a group or a subpopulation over time. And if you do so, you can actually get really important information about exposures and outcomes. And because the exposures are happening before the outcomes, the disease outcomes, you can learn more about what may be associated in a causal way with a potential risk factor, for example. And that's often much more difficult to do in a kind of more cross-sectional survey kind of way. And this can be done both prospectively and retrospectively. There's also serology surveys that can be done where you look at people who've been infected with the virus and when they develop antibodies, and you can do serologic tests to detect the antibodies as well. So this is a way of sort of figuring out who may actually be infected even if they don't know they are because they don't have any symptoms, which for COVID is a big deal because there's a lot of asymptomatic transmission. CDC also conducts seroprevalence surveys, including large-scale geographical surveys, community surveys, and surveys that are focusing on more specific populations at high risk as well. And then there are even other studies like case control studies. There's a whole array which we don't really have time to go through, but I'm happy to give you more information about that if you're interested. And then the last step is really developing guidance for action to slow the spread of disease and lessen its impact. And so this is maybe the most crucial thing is like, how do you take all that information, all the data from the previous steps I went through and develop evidence-based guidelines based on them? And so in this case, all the sort of recommendations were based obviously on historic information that we knew about how respiratory diseases were transmitted, but additionally new information about COVID-19 specifically. And then this has to really be the messaging has to be segmented across these different populations, and the content has to be customized to these different populations as well, and often delivered in a way that's going to have, it's going to be sort of seen as being seen as truthful. For example, there might be communities who might be fearful of public health authorities, but if someone in their own community is a disseminator of that data, they're more likely to be trusting of it. So there's a lot of thought process that goes on this side, and unfortunately, it's often not maybe given as much attention. But it's data in itself doesn't really translate into action. You have to really develop these communication strategies. Now we're on to the final stage, which is how can epidemiological principles and methods be applied to infodemiology and infodemic management? So I'm just going to go through some brief high-level examples. So one is understanding infodemic transmission and dynamics. Often when we do contact tracing or we do case cluster analyses, we are looking at how who's been infected with a virus, for example, is infecting other people. And you can potentially do something using a similar paradigm for tracking infodemic transmission. The thing is, it's much more complicated because a virus is a strand of RNA or DNA. It doesn't have a brain. There's a whole lot of cognitive processes involved in terms of how misinformation translates into shifting attitudes, values, trust in the information source, and how that eventually impacts upon behavior, individual behavior. And this involves, complex psychological and behavioral science modalities in terms of understanding that. So it's much more complicated. We'll talk more about that. But you could also look at descriptive and analytic methods for surveillance and research, where here the principles of person, place, and time could be applied to infodemiology. And also integrated infovalence platforms. So we saw the weekly WHO global report looking at where the virus was, were sort of based on epidemiologic indicators. And the same thing can be applied and has been applied to infodemic measures, such as the distribution of rumor, stigma, conspiracy theories, and how it's distributed across countries in the globe. And then also how rumors, stigma, and conspiracy theories are associated with COVID-19 are distributed as a function of time as well. And these are really similar paradigms to what we were looking at earlier with public health surveillance. And this is based on a paper by Islam and colleagues that came out recently in the American Journal of Tropical Medicine and Hygiene, which is interesting in itself that a paper based on infodemics is actually making it into mainstream public health journals. It's a good sign. So also informing info surveillance methods. A lot of what we do with public health surveillance is involved in detecting disease or an outbreak of an infectious disease, for example. Well, you could use the same kind of methodologies to detect an info burst in terms of monitoring infovalent data, which results in an info quake and would then be detected and acted upon as well. So again, there are similar modalities that could be used, like real-time integrated systems for doing that. A lot of thought has already gone into that by a lot of people, but that's just the principle I wanted you guys to understand. And then there's also how infodemic insights into health fit into the health authority process. So I showed you that diagram, remember, about how we have these different reporting structures from the subnational, national, and global level. Well, similar processes could happen in terms of systems and structures, in terms of how information flows and sort of the various stages in terms of infodemic management through public health systems and other systems as well. There's a lot of the sort of steps involved in that. The structures and systems could all be relevant. And then I think this is a nice graphic that shows like how what we do in epidemiology, which is in sharing information really rapidly, where you might have an outbreak occurring in one place. If you start to see another that similar outbreak in somewhere else, or an epidemic, you know that a pandemic is occurring. And this sort of communication across countries in epidemiology is crucial for knowing, how that distribution happens, and with air travel and with just the tremendous population movement across the globe. This is a vital part of what we do in epidemiology. Well, the same thing could apply to infodemiology in terms of having integrated systems across countries to allow for this rapid detection, because misinformation doesn't know geographic boundaries. Social media platform are shared globally across countries around the globe, and so it's vitally important. And this is really just to show as a starting point where infodemiology and epidemiology meet. And it's sort of graphically showing the various stages of response. And the ultimate goal is sort of flattening the curve. And then you also have like how different aspects of concepts of managing an epidemic in terms of surveillance, the virus, disease, interventions, can apply to infodemics, where you have social listening, narratives, distrust, interventions as well. And there are different streams that have been associated with that. So as part of the work that's being done, for example, on measuring and monitoring the impact of infodemics during health emergencies, detecting and understanding the spread and impact of infodemics, responding and deploying interventions that protect and mitigate the infodemic and its harmful effects, and then evaluating interventions and learning from those evaluations about what's working and not working to strengthen the resilience of individuals and communities as well. And then the final stream really promoting the development and adaptation and application of tools for the management of infodemics. I don't have time to go through this slide, but for each of those 5 streams I went through, there are more specific steps and that have been identified and objectives too. But it'll be in the slide deck that you'll have. You can go through that later. So I'm down to 2 more slides. This is one about the limitations of epidemiology, and this is a great graphic that shows this is an elephant, which is what epidemiology is represented. It should probably be a unicorn, but regardless, you'll see that there are all these various disciplines that relate to infodemiology, and they all touch the infodemiology in a different way. And epidemiology and public health are just one of those things. And so infodemiology is definitely going to require a broad transdisciplinary approach to its development and the activities associated with it. And so the diverse background that you as participants in this workshop have are really important to know. Also, misinformation is fundamentally different from viruses. And I think I've already talked about this a bit, that, obviously misinformation, the way it spreads, its dynamics are different from viruses, fundamentally much more complex. So they're really going to require this kind of multidisciplinary approach to sort of really advance the discipline. Finally, the role of public health authorities is a complex issue as well, because like the arbiter of the truth in terms of determining whether information is misinformation or not, or disinformation, is something that ideally should really be independent. You can have independent fact checkers, but ways to sort of ensure that it's not corrupted by its involvement in a government system, and that's done in a way that maintains the sort of independence in that regard. And it's a bit more straightforward when you're dealing with like disease outcomes and things that we typically deal with, that we've been talking about in epidemiology. And I think that's going to be talked about in more detail in the workshop too, in your training. And finally, just to cover some next steps that are coming down the pike in terms of building infodemic management. One is building infodemic monitoring, management, and response, more guidelines and SOPs for, and which we're really hoping to learn from you and your experiences too, about how to sort of help inform that process. And then also, as part of really developing an infodemiologist community of practice and research, we have this well established in epidemiology, and there's huge advantages. One of the most important things will be developing a multidisciplinary glossary and terminology guide, so that all these different disciplines have a common reference in terms of understanding how different terms are being used. It's like we're all learning the language of infodemiology through our own lens and what technical background we have. Developing a research agenda with a focus on public health integration is really crucial. How do we cross that bridge between just looking at misinformation and really connect it into a more sophisticated research framework to its impact on disease outcomes, for example, or morbidity or mortality, and the crucial role that the behavioral sciences play in that regard. Also implementing demonstration projects to help define infodemic monitoring, management, and response systems. Again, we have to learn from interventions that are done in certain locations to see what's working and not working, and how to learn from those and then apply the lessons learned. And maybe most importantly, I think, is really building a cadre of infodemiologists, and that's what this training is all about. And in this training, we're borrowing from some of the other training programs that we've been involved with in public health, like the Field Epidemiology Training Program, the STOP training program, and this training workshop is really crucial. I mean, you're the first cohort to go through this, and your experiences and your feedback are going to be really crucial, not only after this workshop, but after you finish the workshop, and serving as mentors to future cohorts of infodemiologists. So with that, I'd like to acknowledge a few people, Liz Wilhelm on my team and all that she's given to this effort, really leading it on our behalf as part of our team, but the whole team has been involved. The whole WHO EpiWin team as well. Rosamund, my epidemiologist colleague, but also Tim and Tina, who've really led the work on the EpiWin team, and CDC, the colleagues in the field epidemiology training program, who made some resources available to me, Kip Baggett and Richard Dicker, and then every epidemiologist and infodemiologist and public health professional working to track and end COVID-19 around the world. So with that, I think I'm slightly over time, and I'm going to stop. Thanks so much for your attention.